Well, we'd like to thank everyone for joining us today with our December webinar, which makes for our 7th webinar. Today, we are joined by Brian Chipman. He is stroke manager at Maine Health, Maine Medical Center, Portland. Brian comes to us with extensive history, who served as a paramedic, care nurse, and flight medic and nurse, correct? Yep. And today his goal for you is to speak with you about stroke screening and severity scoring. If you have questions that you have in the Q&A, exceptionally helpful. And if you could also put in your license number and your name, specifically how your name shows up on your license would be helpful too. That way we can record your attendance. And if you have additional people watching with you, you can put their name in there too and their license number. And we'll get started with Brian.
Thank you, Eric. Thanks everybody for having me. I'm really excited to come and talk with you folks about this today. Stroke is a passion of mine, this has been a program that I've been working on for a while. And so, stroke severity and stroke screening and severity scoring, and you see my name there. And I also included Dr. Zimmerman. She helped me put this together about a year ago when we sort of came up with the idea of putting some education out there about FAST-ED and stroke screening. So even though she's not part of the program today, she was a pretty big part of putting this all together and sort of served as my technical guidance and clinical guidance on a lot of this stuff. So thanks for having me, and I'll get right in. I have no financial conflicts or disclosures to discuss or to tell you about. I'm broke and just like the rest of you, so no worries there. Our objectives for the day: we're going to discuss the prevalence of stroke in Maine and in the United States at large. We'll talk about the types of stroke and their prevalence, how often they happen. We'll talk about the assessment and management priorities, and I'm going to spend a lot less time talking about management because I know you guys know how to do that. You're trained and experienced, and you're out there doing it every day, but we'll touch on it just briefly. We'll discuss the use of validated stroke screening and severity tools, which is really the meat of this and really what we want to partake or impart to you today. We'll talk about the correlation between the presentation of stroke and the area of the brain that is being affected and how you can use that to score your patient. We'll talk about the relevancy of FAST-ED score and its potential to identify large vessel occlusion, and then from that, the care that can be rendered therein. We'll talk about the treatment modalities for stroke, and then we'll end it up. We'll do a quick little FAST-ED scores exercise that I sort of put together on the fly. And so I'm going to try this, and feel free to do it if not, but I've done this program about 5 times now, and when I do it, I usually start by asking this question, and I'm going to ask the question, and if you have the ability to put an answer in emoji format in the chat, Dr. Scholl and Eric and I were just discussing this a few minutes ago, please do. And so the question is this: all of you EMS providers that are out there, my question for you is, as a part of your regular practice, when you're out there every day doing the job, how often when you are presented with a patient with potential that you think might be having a stroke or has stroke-like symptoms, do you perform both the Northern New England Stroke Screening Tool and a FAST-ED? And if you do, put a thumbs up or something in the chat, and we'll kind of keep track of that. And if you don't have the ability to do it, that's okay too. The reason I do this is how this program got started, and where we came up with the idea for this was, the thought process is that FAST-ED is not necessarily being completed all the time, and there are so many advantages to doing it that Dr. Zimmerman and I first presented a version of this at the Samoset conference last year. And we had a group of about 50 people, had a room of 50 people. We asked this very same question, and only about a third identified that they do it on a regular basis. And there's no right or wrong answer. We just want to know what the usage of the FAST-ED is out there. So that's why we asked the question, and Eric's going to kind of keep track of it if you're able to do that. And I'm not going to hold up the presentation much, but that's why we're here today, to talk about FAST-ED and to encourage everybody to use it. And I've been an EMS provider, so I know that a lot of times you're given directives to do things. And sometimes the rationale behind it is a little murky. And so my goal today is for you to walk away from this saying, I'm going to do a fast ED because it's a really important thing to do, and here's why it's a really important thing to do. And I'm going to teach you some really cool new words that you may not know that you can pass around the dinner table, and everybody at your dinner table will think you're really smart. So stand by for that. Stroke prevalence and challenges in Maine. So our stroke patients are many, about 3,000 per year, a little bit more than that, and we're spread very wide geographically. The neurologists who are the experts, particularly vascular neurologists, who are the experts in stroke care, they're few and concentrated geographically. There's only about 40 neurologists in the state of Maine, and not all of them are actually in practice. And most of them are concentrated in the lower half of the state. Not surprising, that's where most of the population is, but causes some issues as we go along. The emergency departments across our state bear the brunt of initial acute stroke management, and outcomes from stroke are largely influenced by time to treatment. In fact, what we like to say is stroke is exquisitely sensitive to time, exquisitely time sensitive. And we know that the best outcomes in stroke occur when there is a timely and coordinated effort between all the players, starting with EMS, the ED clinicians, neurology. And then the question is, how do we get there? And so this picture that's on here is a slide that I use for telestroke. I'm a telestroke program manager. What this slide represents is each one of those round blue round things with a shadow around it represents a telestroke hospital. And so telestroke is a method by which, instead of bringing the patient to the neurologist, we bring the neurologist to the patient by utilizing technology and audio and visual and whatnot. And so it looks great because it looks like we have really good coverage, but the reality is we don't necessarily have that great a coverage in order to get neurology to the bedside on a regular basis. And so that's why everything that we do from an EMS and an ED perspective is so important, because it's so time sensitive. Stroke is the 5th leading cause of death in the United States. It used to be 4th, but it got beat out by COVID. So this data is a few years old, and it's the 6th leading cause of death in the state of Maine. It's a leading cause of serious long-term disability for adults in the United States. And I think this is really, really important because if you look at that next bullet, stroke reduces mobility in greater than 50% of stroke survivors age 65 and up. So more than 50% of these folks that have a stroke in the United States are going home with significant difficulty, an outcome that is not perhaps where they would want it to be. Stroke represents a healthcare cost of $53 billion per year. That was in 2017, 2018. So you guys, you're in the healthcare system. You understand what this is all about. It's probably substantially higher than that right now, but I had a hard time finding anything, a nice hard number for that. A stroke occurs in the United States about every 40 seconds, and a death from stroke happens about every 4 minutes. And this all comes from the CDC. What is a stroke? I know you guys know this, but sometimes people like to have sort of a nice, simple definition. So what I did was, to create this sort of definition, is I went to my experts here at Maine Maine Medical Center, and the vascular neurologists that I work with, and said, develop me a really simple, nice explanation that encompasses all of it. And this is what we came up with: an abrupt cessation of blood flow to an area of the brain, spinal cord, or retina that leads to ischemia or infarction of neural tissue. And so why that's important, I think, from a stroke, from a understanding perspective, is there's that ischemic zone, which is tissue that's perhaps injured but still recoverable. And then there's that infarct zone, which is not recoverable. And it's all about flow. It's all about getting enough flow where it needs to go all the time. And again, we talked about things being exquisitely time sensitive. The brain is exquisitely sensitive to a lack or an interruption in flow or oxygen nutrients to that tissue. So that's where we came up with for this. The two types there is ischemic stroke and hemorrhagic stroke. So ischemic stroke is a clot, and a hemorrhagic stroke is a little bit of bleeding into the brain and whatnot. And we'll go into this just a little bit further as we go along here. Circulation of the brain. So it's pretty immense. There's a lot. There's a lot of vessels there. There's some big players, and those are the ones that we worry about the most. And what we've done over the years is what they have done over the years is they've sort of broken it down into large vessels and small vessels. But now in the past few years, we've started to say maybe there's some medium vessels in there too. So we're not quite at the point yet where on a regular basis, we're saying this person has had a medium vessel stroke versus a small vessel stroke or a large vessel stroke, but we're starting to see it populate, and it is going to kind of get to that point. But so for purposes of today, we're going to talk about large vessel and small vessels, but recognize that there's some variation there and whatnot. And when you look at this picture, you see there's some big guys in here. There's some really big guys in here. There's this guy here. Whoops, hold on. Grab the right. There we go. Oops, back up. All right. It's this guy right here. Here's your basilar artery, great big guy. Here's your middle cerebral artery, another big guy. Here's your posterior circulating cerebral artery. There's a big guy as well. So those are the folks, those are the vessels that we see a lot of strokes in. And they're important because those are all large vessels. The small vessels are important too. But what I want to point out to you is that the larger the vessel, the greater the area that's going to be affected one way or the other. And the other thing I like to point out about this slide is this is a really pretty illustration, and all the vessels are nice and big, and they're perfectly proportioned, and there's no sharp turns or anything like that. But the reality is the slide that I gave away the details on, that this is what it actually looks like. The vessels are not always nice and straight. They're not always perfectly aligned. There's some tortuosity there, like here, where things look a little different. So remember that it very rarely looks like this. It almost always looks something like this, and this is how strokes happen, because those vessels are not perfectly lined out, perfectly lined up, and nice and straight without any sort of twists or turns to go along. The stroke types. So you guys know this, but it bears repeating and just talking about a little bit and give you some data around them. Ischemic stroke, a clot blocks an artery. It accounts for about 85 to 90% of all strokes that occur. And they come from a few different sources, the most common being atherosclerotic vascular disease. These are folks that get some plaque buildup. And anytime you have blood going over a not smooth or narrowed surface, you're going to build clots. Your body's going to do that. It's just natural. Cardiac embolism, these are your folks that have AFib, which accounts for about 25% of all strokes out there. So folks that have either occult or known AFib, and they perhaps are not anticoagulated, pretty high risk for stroke, and it happens pretty often. Cerebral small vessel disease, these are those very small vessels that we talked about, and I'll go into it in just a minute, but they're small strokes. They tend to be deep in the brain. They're really tiny vessels, so even a really small clot can cause a bit of a problem. And then there's some other less common causes of ischemic stroke, such as arterial dissection, vasospasm, blood disorders, infections, things like that. One that we saw of recent times was COVID. Actually, in New York City, there were 5 cases of 45 to 55-year-old men who presented, and their only risk factor turned out to be that they had COVID, and they all had strokes based on some clotting disorder that happened with COVID. So that's still out there. Hemorrhagic stroke, on the other hand, accounts for about 10 to 15% of all strokes. It's a blood vessel in or around the brain that lets go. It can be, typically it's from uncontrolled hypertension over a fairly long period of time. The vessel just gets friable and weak and lets go. It's the same principle. There's no clot there. It's just that the pipe gets broken, and all that nutrient and oxygen-rich blood doesn't go where it needs to go. It leaks out somewhere else. Thing about hemorrhagic stroke is there's oftentimes not a whole lot we can do about it. It's often supportive in nature, preventing secondary injuries, and it has a much higher morbidity rate, morbidity and mortality rate than ischemic stroke tends to have. The 2 types are intracerebral. As I said, it's usually from hypertension, uncontrolled hypertension, and then a subarachnoid hemorrhage, which is about 20% of all hemorrhagic strokes, which is a vessel on the surface of the brain ruptures. It's usually from an aneurysm. And when your aneurysm is when your garden hose in the summer, develops a space in between the inner lining and the outer lining and blows up and blows up and blows up. Nobody knows about it until it finally lets go. Not a great scenario, but we're making some advances with that too. And so whenever I talk about stroke, one of the things that it really impresses me is when we talk about treatment modalities for stroke is I want to put this in your head, and I'm sure there's folks on there, there's quite a few people on this webinar today, some folks who have been in this longer than I have. My guess would be that many of you probably remember when I went to paramedic school back in 1991, there was no real treatment for stroke available. There was some, and there was the beginnings of it, but for the most part, the protocol for EMS was start an IV, give them oxygen if they need it, take them to the hospital. Not a lot we're going to do for them. We're going to get them into rehab as quickly as we can. And in our lifetime, in our careers, we've seen this huge change, a great change, where we're actually doing a lot of treatment for stroke now. So keep that in mind as we go a little bit further along. The vessel types are types of acute ischemic stroke. So small vessel or lacunar stroke. And we talked about that. Those are the very small vessels. They're occlusion of a terminal artery, fairly deep in the brain usually. They can present with some pretty profound symptoms, depending on where they happen. But they're only amenable to thrombolysis or clot busters versus large vessel occlusion strokes, which are occlusion of a primary artery of the brain. And those are the big ones we talked about before, your vertebrals, your basilar, posterior cerebrals, your internal carotid arteries, your middle cerebral artery. Keep your eye on that middle cerebral artery. We're going to hear about him again. And your anterior cerebral artery as well. Now, what's a TIA? A lot of folks ask this question, and this is a point that the science has really never been able to completely explain what a TIA is. And in fact, over the years, what we've said is, it's a mini stroke. And as we sort of look at it, this is the most recent definition, if you will, from the American Stroke Association, which is a byproduct of the American Heart Association. It's a transient episode of neurologic dysfunction due to focal brain or spinal cord or retinal ischemia without acute infarction or tissue injury. So what does that mean? It means that there's no core infarct there, there's no dead tissue, and there's no tissue that shows signs of damage after a period of time. That period of time is the moving target. It was about 24 hours last I knew. And up to that, it had only been a few hours here or there, whatnot. So it's one of those things where we're still trying to figure out what a TIA is and what we should call it. And the question becomes, should we be calling it a mini stroke? And part of me says, probably not, because it's not truly a stroke, because there's no infarct there. There's no damaged or infarcted tissue or dead tissue. But I think the value that we can derive from your patient who you meet in the field, who says, and you begin your examination of them and you're getting that history and physical, and they say, well, I had a mini stroke. The value in that for you is, I would call that a warning stroke. If they've had a TIA, it's pretty likely that what they're having now might indeed be a stroke. About 25% of all patients who have a TIA actually progress to, at some point in the future, having a full infarct. So I don't like the term mini stroke because I think it's a bit deceptive, but I think it has value. And I also told you guys to keep an eye on that middle cerebral artery, and here's the reason why. About 50% of all ischemic strokes involve the middle cerebral artery. And the reasons for this are sort of interesting. One would think that the majority of times clots would build and get stuck in those smaller tortuous vessels, and truly that does happen. However, the middle cerebral artery has a relatively direct and large caliber compared to the other cerebral arteries, and it makes it more susceptible to embolism and thrombosis because the blood moves through it at a higher volume and a faster rate, so more volume and pressure. The MCA also arises from the internal carotid artery, which is a common site, for whatever reason, for atherosclerosis. So basically, plaque builds up in that PCA, and blood traveling over it It's not a nice smooth surface. It's stenosed. It's narrow. It might be a little bit rocky, and that's where clots build. And they build there and they sit there until enough pressure gets through there and dislodges once, and then it travels down to the MCA and creates that clot. So keep that MCA guy in your head because he's a problem. Small vessel strokes, as I said, they're often called lacunar strokes. And the three examples that I have here are sort of the most common ones. Picture A is the lenticulostriate branches of the middle cerebral artery. And those arrive off the middle cerebral, and they're usually fairly deep in about midbrain, roughly, sometimes deeper as well. The thalamogeniculae arteries off of the PCA, which is over here on this side. And then off your basilar artery, your paramedian perforators from the basilar artery, and those are kind of problematic because they end up really affecting your brainstem there, where all kinds of bad things can happen. Now, the problem with small vessel strokes in the acute phase, less so from an EMS perspective, more so from a perspective of getting into the emergency department, is small vessel strokes typically don't have any findings on CT in the early phases, right? It takes a while. So here's this patient that is having a small vessel stroke at hour 1, and this is about hour 12. You don't start to see real differentiation in the gray-white matter in the brain for quite a while. And so that's why we can't, in the old days, we used to just do a CT and go, yeah, we see something, we don't see something, and we move on. And then if we thought there was something big, we'd do a CTA. And we just don't do that anymore. We do not do an angiogram every single time because the small vessels don't show up. And so a lot of the time, when we decide to treat aggressively for small vessel strokes, it's based on history and physical exam. And part of that physical exam, which becomes really important when we're talking about making treatment decisions like thrombolytics or clot busters, which, have some risks and some benefits to consider. Part of that decision is what sort of exam came out of the field, what sort of exam came from EMS. You see over on the right side there, that's what it looks like after a period of time. Large vessels, this is the money shot. This is what we're after right now. These are the big strokes, the big vessels. And when you have a large vessel occlusion, they tend to be way more serious. They tend to damage a much bigger area. The symptoms and the deficits are much more severe. And you can see why in this picture. This guy's right MCA. It's got a big clot. There's nothing there. The flow comes in and it stops. This whole side of the brain is not getting flow. This is the same picture, just with the contrast reversed, looking at it from a gray-white to a white-gray, whatnot. So I think I like this picture because I think it shows how easily the brain can get damaged from a large vessel occlusion stroke from that guy who we said who was the problem, that middle cerebral artery. And just a couple of examples of how this sort of happens. We talked a little bit about this, but over on the left side here, here's your carotid artery in your neck, and you've got some plaque buildup because you ate too many cheeseburgers or whatnot over the years. So here's your, keep doing that. I'm sorry. Here's your okay, I give up. You build clot over in that carotid artery. You build plaque in that artery. You stenose that artery. Blood going through, gets narrow, picks up a clot that breaks off, a blood clot that's been sitting there for a while, travels up and lands up here in your brain somewhere where you don't want it to. And that's where you get your stroke. And this is sort of a close-up view of it. And then this picture over on the right side here is what it looks like for that atrial fibrillation. Again, same idea. The atrial fibrillation, the blood is churning in the atria. Instead of pumping out smoothly, it's churning around. When blood churns around, it activates the clotting cascades. Clots are built. The problem with atrial fib is that you build a lot of clots in a short period of time, and they go everywhere. And importantly, they go to your brain, and that can be be a pretty big problem. So why is LVO stroke a focus? Well, we talked a little bit about this already, but LVO strokes tend to be way more severe due to the involvement of much larger cerebral arteries. It's far more territory at risk. LVO stroke tends to have a 5-fold increase in mortality, a 3-fold decrease in good functional outcome. Now, this study is from 2009, Smith et al. But it's probably about the same. The other piece about strong LVO stroke is the success rate of reperfusion with alteplase, which is sort of the clot buster we used forever until about 3 or 4 years ago, when we all switched to tenecteplase, was around 10%. So if you had a stroke that involved your left middle cerebral artery or your right middle cerebral artery, and we gave you TPA, it only had about a 10% recanalization rate from that. And that was from Campbell et al. In 2018. Now, we have all switched to tenecteplase, which is called TNK. It's the same lytic that we've been using in the cardiac world forever. It's a much better mousetrap, it would seem. It has about 400 times the affinity for fibrin. So what it to make it really quick and simple, tenecteplase goes into your body and it activates your endogenous tissue plasminogen activators to help break up clots. So you've got these things floating around in your body all the time. Tenecteplase goes in there and makes them work harder, better, faster. And what we're seeing, the early data, there's nothing really quite published yet, but there's some early data out there about TNK, which shows it's leaning towards being a better lytic. Still, probably not going to achieve more than about 15% over that 10% that we see now. The other part about large vessel occlusion stroke is it's amenable to endovascular therapy, and that is huge. And this wasn't even being talked about when I was in paramedic school, and it's only been sort of mainstream now for about 10 years, a little over 10 years, I guess. It's an amazing thing, and it's changing people's lives, and we're a part of that. Here's what it looks like, right? So picture A is a head CT showing early ischemic changes. Remember I said that small vessels typically don't begin to show early effects on a non-contrast CT, which is what this is, meaning there's no dye injected in that we can trace around. But in large vessel occlusion strokes, you do often see that, and this gentleman's left middle cerebral artery has got an occlusion there, and you can kind of see there's already some differentiation between the gray-white imaging there, and that's basically infarct beginning to happen. And when you look over at the CTA, you can see that the area that it's involved in, and you can see there's not a whole lot of flow on this whole left side of this man's brain. Picture C is the diagnostic cerebral angiogram that they took when they were actually going to get that clot, and we'll talk about that a little bit. You can see comes up through here, and right there, boom, there's no flow, and there's no collateral flow either, which means there's no flow going around that thing too. So this whole portion of this person's brain is really struggling right now. And then picture D is what it looks like after they remove the clot. That first, we got the clot out, and you can see good perfusion beginning to occur across this whole brain field. So this is why large vessel occlusion stroke identification is so important, and why EMS has such a big piece of it. What's this look like on the perfusion side? Well, this is where I teach you the really, if you didn't already know it, the really cool word that you can use around the dinner table and everybody think you're really, really smart. When we decide whether or not we're going to treat these patients with endovascular therapy, we're going to put that wire in and go get that clot. It's a high risk thing. It's just like thrombolysis is. And what we look for is this is a special kind of imaging called CT perfusion imaging. And what we're looking for is a small core. That core is infarcted tissue. There's nothing we can do about that. We're looking for that larger penumbra. We're looking for that big area, this area in green that is ischemic, meaning it's hungry for oxygen and it's starting to have some damage, but it's still salvageable. And so when we talk about getting a patient through the door into the CT scanner for a quick CTP and then directly off to the interventional radiology suite, this is what we're looking for: small core, big penumbra. Use penumbra at the dinner table, and people will think you're smart. I try it at home. It hasn't worked yet, but someday it's probably going to work. And this picture over on the right-hand side is just kind of the same thing. It's just a different view of it. And you can see, here's your core right here. And this is all penumbra. This is all area at risk. And that's what we're looking to save. That core, there's not a whole lot we can do about that. But that penumbra, that's the piece that we're going after right now. That's where we all make the difference. So that's what it looks like for us, right? Or I say us, it's not me, but here in the hospital, when Dr. Scholl, Dr. Zimmerman, and the neurologists, neurosurgeons, and all the experts here, when you bring your patient in, that's what they're looking at the physical exam, and they want to know what you found as well. But our big piece is, what's that imaging look like, right? For you folks, and for all of us, I guess I should say, what does it look like for us? Well, I'm going to talk about these three first, because these are the most important, because these speak to about 80% of all strokes: facial droop, limb numbness or weakness or paralysis, and speech difficulties. About 80% of our strokes occur in the anterior circulation, and they typically present with one or all of these things. There are others. There are other symptoms. The key to all of it with stroke, for me, is this is abrupt onset. There aren't very many people or patients that begin having a stroke at 4 o'clock in the afternoon, and at 11 o'clock the following day, it finally gets to the point where they go to the hospital. Usually a stroke is they're watching TV and all is well, and they have a symptom. Boom, that quick. So when you think of, what is this a stroke, when you're asking yourself that question, is this a stroke, abrupt onset puts it right at the top. If it happened all of a sudden, my world, it's a stroke right off the bat. We're looking for unilateral weakness of the face and or limbs. Same thing, unilateral sensation deficit, commonly the face or the limbs. We're looking for speech disturbances, and we're going to talk about dysarthria, because third speech is really important, and it's a part of the FAST-ED. We're also going to talk a little bit today about aphasia, because aphasia, although it's not part of the FAST-ED necessarily, it kind of is, and I'll talk about that in a minute. But aphasia is hard to sort of figure out, and hard to understand, and hard to pass on to the next people. So we're going to talk about that, and it is a piece of the FAST-ED exam. It's just not as highly considered, I guess. Persistent dizziness or vertigo that's not triggered by changes in position or an abrupt loss of balance. Balance is the big one, and dizziness is pretty important too, and I'll talk about that in just a minute. Dystaxia, unilateral uncoordinated movements of a limb or both limbs on one side of the body, or a gait disturbance. And I have an example here I'll show you in just a minute. Vision disturbances, painless loss of vision in one eye, or loss of a field of vision in one or both eyes, and that's usually the best way to sort of think about this. You lose your peripheral vision in both your left eye and your right eye simultaneously. That's a stroke until proven otherwise. Or diplopia, double vision. Sudden onset of severe headaches usually speaks more to a hemorrhagic stroke versus a acute ischemic stroke, but it does occur in ischemic stroke. And then abrupt onset of confusion or agitation. And this is typically considered rare as a primary stroke symptom. It often gets called that, but it often is more an effect of aphasia, because aphasia is incredibly frustrating for that patient. They know what they want to say, but they can't say it, or they can't understand what it is you're saying to them, and they used to be able to, and that can create people, make people have some pretty significant agitation or confusion. So is it confusion or is it aphasia? And I'm just going to show you this hemiplegic gait. Now, this is kind of interesting. Hang on, move on this. So I know you folks don't typically get a chance to walk your stroke patients, but sometimes you do. And if this is what they're doing, and this is one of their symptoms that they didn't have half an hour ago, that's a dystaxic gait. That's a hemiplegic gait. It's important. All right. This is interesting, right? We know, and I said it a few minutes ago, and I'm going to say it again because I think it really bears repeating. 80% of our strokes that we see originate from the anterior circulation, and about 80% of them also have one of these symptoms, either facial droop, arm, leg weakness, or speech trouble. FAS, right? FAS. We're at FAS. We just got to get to T, E, and D, right? But 80% of your strokes. So if your patient has facial droop, probably an anterior, it's a stroke until proven otherwise. Arm, leg weakness, speech trouble. Think about that. Think about the fact that it's the anterior circulation, those where we can go with endovascular treatment and get those clots out, right? But we need to talk about posterior circulation stroke too. And posterior circulation stroke is a bugger. It's hard, and I think Dr. Scholl could probably really speak to this. He's probably seen his share of these. But one, they only represent about 20% of all strokes that happen, but they have about a 25% delayed diagnosis or misdiagnosis rate, something like that. And the reason is the symptoms tend to be so vague. In fact, I think the primary or the number one symptom that patients report is dizziness, nausea, and headache. Boy, that could be like, from a differential diagnosis perspective, that could be about 50 different things right off the top of the head. Your posterior circulation strokes typically take place on the vertebral arteries, which is way back here against your spine. And the way to sort of figure out whether or not this might be a posterior circulation stroke is, one, I would recommend if you're out there in the field and your patient says, it's so dizzy and I can't stand up straight and I feel nauseous and sick to my stomach. If you can walk down these other other four things, and they might have some anterior component symptoms as well, that should lead you in the direction of perhaps from the field saying, well, this kind of sounds like a posterior circulation stroke to me. He's dizzy, he's got double vision, he's not speaking, he's slurring his speech, he can't swallow, and he has dystaxia or some other thing. So be careful. Posterior circulation strokes are kind of scary because they're hard to figure out, and they can have really significant effects as you go down the road. Why does this all matter? And I talked a little bit about, time is brain and the significance and clinical significance of it. And so, the number one bullet point on this slide is the second one down. There's an estimated that 1.9 million neurons die every minute that a stroke is untreated. That recanalization or reperfusion of that brain it occurs. So 1.9 million neurons. Now, inevitably, somebody usually asks, well, how many neurons does the body have? And I think it depends on who you are. There are people in my circle who would say, Brian, you better not have a stroke because you don't have any room to spare there. But the truth is, it's somewhere around 86 billion. So that's quite a big number. But 1.9 million neurons die every minute in untreated stroke, and along with that, you lose a bunch of synaptic junk connections, and you lose 7.5 miles of myelinated fibers. I love that third bullet down. The ischemic brain age is approximately 3.6 years for each hour that cerebral flow is interrupted. So think about that. The brain, your 35-year-old, your 55-year-old brain in an hour is now almost a 60-year-old brain. And the average duration of a non-lacunar stroke or a large vessel occlusion stroke is right around 10 hours, something like that. And this imaging over on the right-hand side here sort of shows that progression of what it looks like. Now, we didn't do, this slide, this imaging wasn't done to sort of make this point. This was a patient that had a large stroke. There was absolutely nothing that could be done, and so they kind of tracked it as it went along. And you can see that the stroke grows pretty substantially over a 2-day period of time. In fact, quite a bit, from the 5-hour mark to the 13-hour mark. And then in this imaging down here, you can see, remember, this is just one slice. This is the same slice all the way across. It gets bigger. But as you look down deeper into the brain and more slices, you can see that there's quite a large area of the brain here, which, suffered significant infarct and is never going to recover. It's kind of hard to rehab from something like that when you take out about little over a third of your brain. What can we do? This is the beauty of it, right? Like I go back to what I said in the beginning. Back in 1991, there was very little going on for stroke, acute stroke management. But now we have two, kind of three, treatments that we can do, and we're starting to make a difference. We're starting to get people out of the hospital quicker. They're not having to go to rehab. They're going home with services, or they're going home completely deficit free. And we're starting to see it on a regular basis all the time now. Number one is thrombolysis or clot busters, and we talked a little bit about that. There are medications given to dissolve the clot and restore flow. There's some challenges, and the number one challenge really is that it's got to be administered within 4.5 hours of that last known well time. Last known well, FAST, so FAST. We got T done. And there's some significant risks with thrombolysis. And so not only do we have to get it in within 4.5 hours, but they got to be the right candidate. They can't have any bleeding disorders. They can't have had any recent trauma, and they can't be on any anticoagulants already, because the risk of putting yet another clot buster into the system could be a big problem. And the reason that we can only give it we try to only give it within 4.5 hours is, vessels that go without blood distal to where that clot is, they get kind of friable. And so the brain is a high pressure system. If you, over the 4.5 hour mark from time, you reintroduce flow sort of rapidly like that, the risk of that vessel not being able to withstand that sudden pressure is fairly high. And you've given them that clot buster, so they're going to bleed like crazy. So the other challenge that I didn't put on here is you've got 4.5 hours, and across the state of Maine, what it looks like to us from the data that I collect, most of them don't even show up don't even present to the hospital for about 60 minutes. So we lose an hour right off the top. Endovascular therapy, this is the money shot right here. We mechanically extract the clot from the affected vessel and restore flow. They insert a really long wire into the groin. They use fluoro and contrast, and they feed it all the way up into the brain. It's amazing what they can do. Find that area of clot, push it all the way through the clot, deploy a stent, pull the clot out, and you get flow reestablished. The challenge is it's only for large vessel occlusions right now, but excuse me, we're starting to see that they're going after clot that is deeper than we ever used to be able to do, and in smaller vessels. And so as technology comes along and gets better, and skill and proficiency gets better, we're going to start seeing even more great saves with endovascular therapy. And then, sort of the Super Bowl of it all is thrombolytic and then endovascular. So, if your patient presents at an outside hospital, or you take your patient to an outside hospital, and they get some thrombolytic on board, begin to break up that clot, and then get them to the place where they can have an endovascular therapy procedure. The dual therapy is associated with much better outcomes in that instance. And part of it is because the thrombolytic can provide some collateral flow for places that may have some clot. The other part of it is we tend to move really fast with these patients, and time is brain, and it's exquisitely time sensitive. So it's an exciting, cool time. This is what it looks like. This is kind of a illustration of what it looks like when you get thrombolysis. There's Brian. He ate too many cheeseburgers over the years because he really loves cheeseburgers, and he got some stenosis in his middle cerebral artery, and then for whatever reason he had a clot break off somewhere from downstream, and it totally occluded that, and there's no blood flow beyond. Here comes that purple thrombolysis, and it goes right in and it breaks up the clot, and flow is restored. Pretty cool. This is endovascular therapy, and I don't have a great video to show you this. There are videos that are out there, and you can find them on YouTube and whatnot. The problem is they're all associated with typically the devices that are used, and so I didn't want to put a video up there that showed the actual name of the device and the company that did it, because that just felt like I would be sort of a conflict there. So, but this is what it looks like. It's a piece of chicken wire on a on a catheter, and we feed it up all the way up into the brain. They feed it up all the way into the brain. They go all the way through the clot. They grab it. They deploy the chicken wire. They grab the clot and they pull it out. So picture A here, you can see there's there's no flow, and that's your left middle cerebral artery, and there's no flow up in here. They went in, they put the catheter in, they got the clot, they pulled it out. Look at that robust flow all through that brain there. Here's a picture of the chicken wire or the stent and the clot that they pulled out. That's a pretty good sized clot there. And what you're seeing here is, this area of brain, this should be your core, and the penumbra would be all the way around it, but it's actually fairly small considering there was this much occlusion and this much brain that was not receiving any flow whatsoever. So it's exciting stuff, and we're a part of it, and EMS is a big part of it, a huge part of it. So that's why we're talking about this today. Your impact, you guys' impact. About 65% of patients with signs or symptoms of stroke utilize EMS to enter the healthcare system. That's just a fact. You guys are seeing them way before we are in the emergency department. Along with that, patients presenting via EMS comprise the majority of patients that arrive within the therapeutic window for thrombolysis. So you're getting to them quicker, and you're getting them to the hospital quicker, and you're getting a lot of the stuff done that helps the system get thrombolytics on board quicker, faster, like starting an IV and doing a great assessment and figuring out what's going on with the patient. EMS utilization is strongly associated with reduced time from onset of symptoms to hospital arrival. We talked about that. And it's also strongly associated with decreased time to physician assessment, faster CT imaging, and definitive treatment. We're saving time, we're saving neurons, lower mortality, better quality of life, and much better functional outcomes, which is where it's all at, right? It's what you guys do, and that's why you do it. Here's my thing, right? This is our EDs every day. This isn't a local ED. This is a picture I pulled off of the internet, whatever. But I think it's pretty reflective of what's going on in everybody's ED just about all the time. I see it all the time across all of my telestroke hospitals. They're all busy. It's controlled chaos all the time. So the question becomes, right? How do you, as an EMS provider, get your patient's clinical problem on the radar of that ED physician who's trying to manage all of this chaos? Well, I ask the next question is, how should we be identifying, scoring, and notifying the receiving ED of a potential stroke? And what about objective stroke severity scoring? And there's some real benefits to doing this. And the first one is it's standardized, right? And I love this slide. I love this graph, right? Because when you look at that, sort of the X, Y there, if you look at it from the X, he's a duck. And if you look at it from the Y, he's a rabbit. That's the problem. Telling somebody that your patient has left-sided weakness is not the same as saying they have a FAST ED score of 6. It's not standardized. It may not trigger off. And what the field provider was witnessing is sometimes difficult to convey, particularly because you're either on the phone, in the back of the ambulance, on the radio, on the way to the hospital. Sometimes it's sort of difficult to do that. Education, training, and experience levels tend to vary quite widely. Distractions occur, technology doesn't work, and human factors, and then there's the telephone game, and the passing of a message multiple times with structural changes to that original message. We've all seen this. They say a patient's story will change 7 times from the time they call EMS until they make it to the triage desk. So those are things that we have to consider when we think about figuring out whether or not the patient is having a stroke and whether they need the quicker push through the system. Maine EMS has a robust stroke screening protocol, and we start with the Northern New England Stroke Screening Tool. It's also known as the Cincinnati Pre-Hospital Stroke Scale. There's no numbers with this. It's either positive or negative. It considers the most common symptomology from stroke that emanates in this anterior cerebral circulation, which are, you guys remember, F, A, and S, face, arms, and speech. Focuses on facial palsy, weakness, and speech impairment. It's quick, it's easily performed, and it's evidence-based, right? So if you do the CPSS, or the Cincinnati, or the Northern New England Stroke Screening Tool, it's got a sensitivity of 82%. So basically, 82% of the time, if they screen positive on the CPSS, they're probably having a stroke. Versus 56% of the time when they screen negative, they're not having a stroke. That specificity. It's important. It's a good thing to do. And a lot of people ask, well, if I'm already doing this, I'm already doing face, arms, and speech, why do I have to take it one step further? And I would submit to you that the reason is this just tells you if we think they are having a stroke, versus the FAST-ED, which tells you a couple of things. One, it gives a severity score, and two, it sort of tells us whether or not we think this might be in a large vessel, like that troublemaker, the middle cerebral artery, right? So in the protocol, this is what it looks like. If you get a positive screen on your Northern New England Stroke Screening Tool, do a FAST-ED, and here's what it looks like. And we're going to go through it all, so I'm not going to spend a lot of time on this, but I just want to point out a couple of things. It's called the Field Assessments for Stroke Triage Emergency Destination. It was developed for states exactly like Maine and New Hampshire and Vermont and any other sort of state with a large rural component, to help EMS providers determine where the best place to take the patient to is if they're a long distance from the hospital that can do all the magic, right? Well, in the state of Maine right now, the only place that can do all the magic, if you will, is Maine Medical Center. So it's less a use for that right now. It's in the protocol, and I encourage you to read it. If you're in that in-between zone, somewhere between 40 minutes from Maine Med and 40 minutes from somewhere else, figure out whether or not you should go to Maine Med first if they have a FAST-ED score that's above 4 or not. But this is what it was developed for. But along the way, people figured out it actually is a really good stroke screening tool. And if you do the whole thing, it's also a stroke severity tool. And it tells us with a fair amount of objectivity whether or not this patient is having a large vessel occlusion stroke. And then, happily enough, FAST-ED also can stand for facial palsy, arm weakness, speech changes, time, eye deviation, denial, neglect, and whatnot. So I guess my point is, if you're going to do only one, now I'm not telling you to only do one, but if you're only going to do one, my preference would be do the FAST-ED. You're covering all the bases. I'm not telling you to only do one because you got to follow your protocols, but if you're only going to do one, do a FAST-ED. The FAST-ED originated from the NIH stroke scale, which is sort of the gold standard. It's used by neurology to objectively score stroke. It's comprehensive, it's long, and it must be done precisely in order to get an accurate score. It's difficult to do quickly because there's many, many components to it. I look at NIH stroke scales all day long. I take a class every year in NIH stroke scale, and I can't remember this off the top of my head. This is a bugger to do. It takes many experiences to become proficient at. The beauty of the FAST-ED is that it pulls the most important pieces out of the NIH stroke scale that speak to a stroke being from a large vessel occlusion, mainly facial palsy, arm motor weakness, dysarthria or speech, best gaze, and extinction in attention or denial. And so it has solid roots, it has a good foundation, and it can really help you find where you need to be. Why do it if the CPS is positive? It's evidence-based. It's both a screening tool and a stroke severity tool. It can be done fast. It gives you a nice numerical score. It helps identify the territory of the brain involved. But most importantly, I think it's a common language between the ED and the EMS disciplines, right? Goes back to what I said with that picture of the chaotic thing. I think it's a lot easier for a physician that's really trying to manage chaos to process and act on, hey, doc, this patient has a FAST-ED score of 6 versus, hey, doc, this patient has some pretty significant left-sided weakness. I think it makes it easier for everybody involved to sort of make critical decisions quickly. But Strengths and limitations. The most important is it's evidence-based, and if you have a FAST-CD score between 4 and 9, it's a 60% chance of you having an LVO stroke. That's pretty good numbers. It helps the initial receiving facility prepare for thrombolytic use as well, and it also helps them think, oh, he's got a FAST-CD score of 7. I probably ought to start thinking about getting this patient transferred now before the patient even gets here. There are some limitations. It primarily only considers the anterior circulation. It's a bit more involved than a screening tool, and it requires a little practice, but easily done. And then my question, is does objective and standardized scoring make a difference? And to sort of speak to this, I wanted to take a lesson from what I've learned here in the hospital, right? Now, here in the hospital, we don't use FAST-ED, although we use it a little bit in the ED here, but nursing uses something called BFAST. It's kind of the same thing, balance, eyes, face, arms, speech, and time. What I did was I looked at 117 thrombolysis patients that started with telestroke, and I figured out their performance metrics. And I compared those patients that had a BFAST or a focused neuro exam completed within 30 minutes of arrival to those who did not. And what I really wanted to look at was, are we faster as a system when a BFAST is done, and I didn't necessarily limit it to BFAST. If a FAST-ED was done or a focused neuro exam was done, I included that too, as long as it was in 30 minutes. And when you look at it, the holy grail of thrombolytic care and stroke is that door-to-needle time. And what we want is a door-to-needle time of 45 minutes or less. And so if you look at the bar all the way over to the right, you can see that those patients, these are medians, right? So this is sort of a snapshot of what goes on all the time versus what goes on the outliers. But it's about 13 minutes faster if a BFAST was done or a focused neuro exam than when no BFAST was done. And so I think we can apply that same sort of lesson, if you will, to the EMS world. I think, and the reason I didn't do the study or look at all this is I just don't have access to that data. I don't even know how often a FAST-ED is being done, but I'll bet you that we could see the same thing if we were doing a FAST-ED on a much more regular basis and we collected that data and looked at it. Things to think about for the future, kind of interesting stuff. Real quick, I want to walk through the FAST-ED exam. I know you guys all know a lot of this stuff, but I just want to hit a couple of high points for you and go on. Facial palsy, it's pretty simple, right? Do they have it or do they not? And the highest you can score is a 1. If there's obvious droop there, it's a 1. If there's no droop there, it's a 0. There's no 2 involved in that. So facial palsy is probably the easiest one, and it's the first one that you see. Arm weakness. So a couple of things with this. When a patient has a stroke, is having a stroke, and there is arm weakness or what they call pronator drift in one side or the other, it typically speaks to damage in the area of the corticospinal tract, which goes all the way up through the brainstem and lands up and about here. So any stroke in that sort of parietal area of the brain may potentially cause arm drift. What you're looking for is you have them extend their arms out to 90 degrees if they're sitting, or 45 if they're supine. Ask them to hold them arms in place for 10 seconds. Typically, we like to have them do both arms at the same time, but if they're not able to lift that left arm or the right arm or whatever at all, then there's your answer. You have that. It's a 2. But if they can get both arms up, and there's no drift, they're 0. If they drift but they don't hit the bed, that's a 1. If they drift all the way down to the bed, that's a 2. Now, somebody always asks me, palms up, palms down, does it matter? I can't find anything that speaks to it mattering one way or the other. And indeed, my conversations with my neurologist, medical director here said, no, it doesn't matter one way or the other. Palms up, palms down really probably doesn't matter all of that much. You can probably do it either way, and you're going to get about the same results. Key is to have them close their eyes as well. Speech. So we talked a little bit about this, and what you're looking for is you want to note that spontaneous speech and ask the patient to identify 3 common items, and then ask the patient to show you 2 fingers. So 2 things you're looking for here. 1, you're looking for dysarthria or slurred speech, but 2, you're looking to see if they can identify those things and if they can articulate what those things are, and they can follow along with you with what you're trying to accomplish here. So the first part of that, dysarthria, that if they're dysarthric, then that area of the brain that affects their ability to form words and enunciate is impacted. The second piece of this speaks to that aphasia piece of it, either expressive or receptive. And the three items that I recommend folks use are really common items. And I think most EMS providers typically have all three of these things with them. One, they have a phone. Do you know what this is? A pen, and a pair of scissors. And the reason I like to use those three is, one, they're all really common. You probably have them with you when you go on a call. And then the last piece of it is you're going to ask them to show me two fingers. And the important piece is, do not demonstrate that. You're going to ask them, what is this? What is this? What is this? And then you're going to say, show me two fingers. The first three items is to assess their ability to express, whether they have expressive aphasia or not. The nice thing about scissors is it's easily slurred. So if they have dysarthria, you're probably going to pick it up with, when they say scissors, they're going to say scissors instead of scissors. And then the last piece of that is, can they follow directions? Can they do what you ask them to do? They understand what you're asking them to do, and that's to show me two fingers. Don't demonstrate it, because then they'll just mimic it. You need a clean look at this. So what is this? What is this? What is this? Did they slur any of those three things? Can they show me two fingers? And then your scoring is up here. Is it normal, impaired but comprehensible, or unable to name any of the items, or unable to follow the command as a 1. And if they can't even speak, or it's totally incomprehensible, that's a 2. Eye deviation. You want to look for their eye position. And typically, when folks have a stroke, it's damage in the right motor, in the motor cortex, typically more on the right, but it does happen on the left as well. And typically, patients will look towards the area of the infarct or the damage that's being done. And so what you're going to have them do is you're going to have them follow either your finger or a pen or something like that. And one, you want to see if they're deviated. If they are deviated, can they cross and break that deviation? And if they can't break that deviation, then both eyes are forced to the same side, one side, and that's a 2. I know we're over here. I'm going fast. This is the hardest one, denial and neglect. With eyes closed, you're going to touch the patient on both arms simultaneously and ask if they feel both sides. And then if they miss a side or they don't identify one side, you're going to show the patient on the side of their weakness, whose hand is this? And it seems like a really silly thing to do to patients, but I put these two things up here. These are the lobes of the brain and what they control. And this right here is a picture of a clock drawn by somebody who had significant extinction. They did not recognize the other side of the world, if you will. And so when they drew a clock, it was all on one side. It doesn't go all the way around. This piece here just does not exist. And Dr. Morris, my medical director, likes to say the organ that is responsible for telling you there is a problem is the organ having the problem. And that's something to factor into your exam when you're looking at these folks. FAST-TD, what do you do with what you find? You add it up, you get the score, you call that code stroke from the field, emphasize during your report if the FAST-TD score is greater than 4, treat them per your protocols, and upon arrival at the receiving hospital, really emphasize that score again. Hey, doc, he's got a FAST-TD score of 7. That's going to resonate with somebody. So, any questions, Eric, out there before I jump into the last little bit of this? Was just a quick exercise to kind of walk you through it.
Oh, no questions in the chat so far.
Perfect. Okay. So this is a quick exercise I put together. I ask you to just play along and kind of give me a score when we get to the end. I used some videos, excuse me, that I pulled off of the internet, off of YouTube, to sort of demonstrate things. They're not perfect, but they're pretty good. And the next rendition of this class, they'll be much better. We'll find some better, we'll make some better ones. But here we go. This is a 58-year-old female with no significant medical history. Her husband called you because she complains of, I can't feel my left hand and arm, and my heart feels funny. On your arrival, your general impression, the first taking a look at her, she's quite anxious appearing. Her husband is with her. He witnessed these symptoms to begin at 2:15. Her airway is patent, her breathing is normal, her skin is pink. She has obvious facial droop on the left side. She's holding her left arm, and her speech seems to be a bit slurred. So you do your Northern New England stroke screenings tool, and you're like, oh, yeah, she's positive for sure. She's got facial droop. She's got, we haven't checked arm drift, but she's holding that, and her speech seems a little slurred. So she's a positive. So knowing this, you say, I know what I'm going to do now. I'm going to do a fast ED score, so I'll have a good way to communicate with the doc when I get there. So here you are. Here's her face. Pretty obvious facial droop there. I think we can probably give her a 1 for that. Oops. All right, here we go. Guys, you guys figure out what you think her score should be. Anybody need to see it again? Pretty clear. Pretty clear what's happening to her. Speech. This is a harder one. And I'm curious to see what people come up with on this, but here we go. Looking through it again real quick. Think about a score for that. Time. Last known well, 14:15, right? So we're still within the window right now. We're still within 4.5 hours. Eye deviation or gaze. We followed one side but not the other. And last one, that hard one, that denial. It's a little bit hard. So we're going to start with the first piece of it. And I think it's really important is to look at how he does this and how the patient reacts. Let's look at that real quick again. Watch what happens. What's really interesting with that is he touched the right side, the left side, and then both at the same time. She identified right side and left side until he touched both at the same time. Then she only lifted her right side. So kind of an interesting piece to that, and that's usually how it goes. Hang on. We got one more. Since she scored for that, we need to ask her about her hand.
Brian, they're not able to necessarily hear the sounds.
Right. There's your fast ED. Hoping you all came up with a score of about 6. There might be a little bit of variation there, but for the most part, it was pretty straightforward. I think that's pretty easy to tell your physician colleague when you get to the hospital, hey, fast ED score 6. I think that's going to resonate with them and make a pretty big difference. So that's my story. Thanks for having me. Questions, comments, concerns?
Brian, thank you for joining us today.
You bet. Thank you. Here is your evaluation piece. And I'll leave that up there for just a second. And this is for the next program. Eric, let me know when you want me to, or let me know when you want me to.
I'm going to shoot some up in the chat too.
Okay. You're going to put them in the chat?
I am putting them in the chat, and I will also email them out to people.
Perfect.
So,
That's all I got.
thank
Only
you
9
everyone
minutes
for
over.
attending today.
Ryan, thank you so much.
You bet.
Have a great day, everybody.
Great job, Brian. Carry on the torch.
Hey, Kate, I didn't know see you there.
Yeah, it popped in. Thank you.
You bet.